Alright. Okay. I'm gonna try and have real content live, and I'm just gonna go and I'll give updates about kind of where I'm at after. So got a request for how to become an ER tech, and I thought, well, there's a bunch of different ways you become an ER tech, and I'll discuss the ways I know best. How to get if you want to get into the ER, and you're not, and that's my phone. I mean, I got a computer. So I just got up 12 hours, so I'm tired, guys. But I'm gonna do it because this is my time. I don't have time otherwise. I can't do it during the day. I'm very tired. So look at that, dude. No sleep. Look at those eyes. Look at those bags. Yeah, baby. I'm so tired. So tired. But here we go. ER tech. So if you want to be in the ER and you want to work as a like one of the PCTs, basically I only have 2% on my phone, so hopefully this will charge. I have it charging on my computer. So to become an ER tech, so there's a bunch of different ways you can do it, and it depends where you want to work. So it depends on what kind of ER teching you want to do. If you want to get the most bang for your buck, find a good hospital to work for. Work for a good hospital, because that's the best way to do it. Pick a hospital. I don't know what specifically, what kind of ER you're looking for. There's pediatric ERs. There's adult ERs. There's a combination of the two. There's trauma centers. There's cardiac receiving centers. There's paramedic receiving centers. There's stroke centers. There's burn centers. There's I think I already said trauma centers. There's a bunch of different kind of centers, a bunch of different receiving hospitals. So depending on what you want to expose yourself to, if you want to be in the ER, and I just don't care what ER I'm going to be in, just want to be in the ER. I mean, you can. I don't know. There's certain rules. Every hospital's got different rules, so I would say pick a hospital. What you want to do is kind of do a little research, and if that means just go into the hospital and walk into the ER and look at the nurses who are triaging the patients and look at the patient population who's sitting in the waiting room at any time given time, and just take a look. See, kind of go on the website, find out what kind of hospital, how many patients they find. If you want to do research, that's kind of how you would do it. Find out like how many patients per year you see, how big is the ER, and what kind of specialties do they receive, right? So depending on those kind of things, will kind of determine kind of good work experience. So you can't just go to your local ER. I mean, you can, but it's not as good. You can't just go to I want to be in the ER and I want to see a bunch of crazy stuff, or I want to do a bunch of crazy stuff, or be exposed to a bunch of cool, interesting stuff. You can't just go to your local ER, okay, because there's some ERs. It's like an 5-bed ER, they have one monitored bed, I don't know. There's small little hospitals, some places, where I'm at, we have big hospitals. We have little hospitals too. So it's not like the East Coast big. We don't have East Coast big hospitals, definitely not. But we have, good high hospitals and not so high volume. And so pick a hospital ideally for me, I would say go and pick a hospital that definitely has to be paramedic receiving. Because if they're not paramedic receiving, 911 calls aren't coming to them. So they're not really, they're walking only pretty much. So if they're not paramedic receiving, that means they don't have base contact, right? So if they're paramedic receiving, they can get contact from EMS, emergency medical response, the firefighters, the paramedics in the field. They can radio in frequency to the hospital, make base contact, and talk with a specialty nurse, right? Hold on a second, sorry. I just want to make sure. My phone's charging. Sorry, time out. Just going on rants here. It's okay. This is how I do it. This is my thing. So, so that's what paramedic receiving is. So you want to go to a paramedic receiving hospital. Make sure you get into a paramedic receiving hospital, and ideally get them STEMI receiving, so they have a cath lab 24/7 on call at all times. Get them stroke, right? So if they have stroke, you can TPA them. You have on call radiology available to scan people. To see if they can do strokes. They have stroke coordinators. If you're stroke certified, you have coordinators and a stroke team, and they have to call it overhead, stroke team stat, into the room, they call it throughout the hospital, stroke team. Someone's got the nurse in charge. So as a tech, right, you have a bunch of duties for code strokes on your side. If your pod has a code stroke, there's a bunch of stuff that needs to happen to get this patient freaking going, and you have a bunch of stuff to do. It's really fun. It's totally fun. But if you don't have a if stroke receiving, you don't get to experience that. You don't get to see them dose out and draw the TPA bolus and the TPA drip. You don't get to see them change their depth sense and do the NIH scale over and over and over. You don't get to be a part of the care, right? You don't get to watch the doctor come in and make that important decision, of calling code stroke and moving forward with, trying to perfuse them. So it's like all kinds of good stuff. Make sure if you can, STEMI, again, like I said, STEMI receiving is really cool too. There's crazy stuff happens as STEMIs come, STEMIs coming in. That's really cool. It's really cool. And you're doing the 12 leads, you get to do 12 leads on the STEMIs. That's freaking sweet. Doing 12 leads on acute STEMIs, dude, very cool. Very, very, very interesting. So that's a really cool experience. So make sure you go to the right hospital. I guess that's the key point I'm trying to drive home there. So once you narrowed down the hospital that you want to, pursue, you can get into that hospital many different ways. Okay, you don't have to just have your EMT at all. You can, and I think I've said this in videos before, but this one's especially for this. So I'll give it, make this very, so let's say you want to be an ER tech. What you can do is, sure, enroll in an EMT class in your local community college. Great idea. Or privately, whatever. They can do an EMT class in like 2 weeks for $800. I don't know how much it is around here. It's like $800 for like 3 weeks, and it's crash course. Boom, EMT, quick. You can go do that. They also have phlebotomy. I think it's $1,700. You can go get your phlebotomy. So you can draw labs, you can do all kinds of, so you get to be even more a part of the team because you get to draw labs all the time. You can draw labs on freaking everybody. Just draw labs on everybody. I wish I could do that. That'd be great. I can't do that. Even as a nursing student, I can't. I mean, as a nursing student, yeah, drawing labs, all, drawing blood, putting in IVs. We can draw central lines. We can help place central lines. We can do all that stuff. We run stuff through everything. So we do everything as a nursing student. But as an ER tech, you can draw labs, which is still cool. Why it says low battery, dude? I hope my phone doesn't burn out on me on this. Okay, so get your EMT, sure, that's a great option. The thing is ERs, they don't want newbies coming in. You got to have some experience and know what the heck's going on. They don't want to train you from ground zero. They want you to be able to train you with just how we run ours around here. This is how you adapt to it. So most hospitals, and I'm just speaking Southern California specifically. They don't want to they're not going to take your resume and see that you don't have any work experience, but you got an EMT cert and you're maybe taking nursing prereqs. If you're taking nursing prereqs and you got an EMT cert, they might take you. Depends on the hospital. They might take you. Or if you're in first semester and you got your EMT cert, there's a chance they might just hire you on from good word of mouth. So I guess that's number one, is word of mouth. You've got your name said or typed up in an email to the right person will get you the job. That happens. That's how it works. It's networking, and that's how people get jobs. You meet people that like you. You do your best to be professional and of good rapport, and do your best to work hard and be a team player. People like you and be smart. People like working with people who are easygoing and who want to do stuff, right? And so, as a nursing student, you can maybe get a referral from maybe one of the nursing preceptors who works at a local hospital, who knows the ER manager, who can send them an email, send them your resume for you. That's one option. That's one way you can do it. Another way you can do it, if you don't have the luxury of a, nursing professor who will hand deliver your resume for you. If you don't have that, your next best bet is to go work on an ambulance. You can go work on an ambulance to get some work experience. So that's another way to do it. Get your EMT, go get your ambulance driver's license, apply for an ambulance gig, start working on a rig for 6 months, and then start applying to local hospitals that you receive to, and you just talk to the charge nurse and talk to the ER techs there and be super cool with them and see if maybe someone would say, yo, there's a spot opening up and you should apply for it, blah, blah, blah. And then scour and put your application in all the ERs you want to go to. So that's the other thing. So that's another way. So that's 2 ways, or 3, I don't know. It's kind of a mixture. There's a bunch of different ways to do it. So another way to do it is become ancillary staff. So ancillary staff are very important in the hospital. We need housekeepers, and we need dishwashers, and we need food service, and we need what else? Volunteer, no, not volunteers. We need food service, cooks. We need cleaners. We need people to do the laundry down there. We need people to strip the beds and clean the rooms, right? So become an ancillary staff. Apply for a maybe food services and work in the basement of the food service and deliver the food. I think I've talked about this. You can do that. You can work as a housekeeper, right? Because the housekeeper's got to clean those ERs when those ERs come in and they're covered in blood and stuff, and they're totally, a wreck after a code, or traumatic full arrest that came in and there's blood everywhere. You got shot in the face, and you're bleeding all over the place. You got to clean all it up. They got to get somebody to clean it up. If you're that guy that's mopping it up and you do a bang up job and you're great at it, and you happen to start talking to people and people just recognize that you're a nice guy and you're cool, you say hi to everybody, blah 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 blah, this that and the other. You start talking to everybody, getting around. Hey, I want to be a nurse. Yo, I want to do what you're doing. This kind of thing. Just put it out there, right? Put yourself out there to this other staff. You've been working there for 6 months. They know your name. They know you, and they know. Hey, you want to be a nurse? Oh, you're in nursing school, or oh, you want to be an EMT. Oh, you're getting your CNA cert. Okay, cool. So you do any of that stuff, and then you're cool with your boss, and your boss likes you. After 6 months, you can transfer. You go transfer to a floor. You don't have to. You can be a non-licensed UAP, unlicensed assistive personnel, a UAP, a CNA, an EMT, ER tech, PCT, all those things are the exact same thing. It's all the same, it's just different departments. It's all the same licensure. It's on the hospital wise, basically the same licensure for most hospitals. Most hospitals take a CNA working in the ER just like they take an EMT working in the ER, just like they take an unlicensed assistive personnel who is trained well in the ER. So an unlicensed assistive personnel can be an ER tech. I was an unlicensed assistive personnel basically. I was actually technically a PCT in the ER for the emergency department. I was a PCT1 for the emergency department. Patient care technician. In ER, patient care technician. They didn't call us ER techs. Well, they did. They call us techs. It doesn't matter. Same exact thing. As a mental health worker working on a psych unit. It's the same position basically. It's the same licensure, same requirement by the hospital. I didn't need my EMT. I had my EMT when I got hired as a mental health worker working in a psych ward. I had an EMT. I had no psych experience. My only psych experience was transporting 5150s, 30 minutes to the local, psych ward. Okay, yeah, I transferred a few psych patients. That's all the experience you need. Okay, you work with psych. You like psych? Okay, cool. Yeah, we'll show you how to do it. Cool. You can take vitals? Great. It's that easy. So it's pretty, you know, straightforward. So even if you're unlicensed, you can mention, hey, I'm getting my CNA. You go get your CNA while you're working part time as an EVS worker, right? Environmental services or something. And you start just letting your boss know, hey, 6 months in, hey, I wanna transfer. I think I want to go to the floor. Oh, I want to work in the ER. You start saying, yo, I want to work in the ER. Well, hey, bro, they could go a bunch of ways. You could talk to the ER director, right? You could have your boss email the ER director or the manager. Have your manager email the manager, say, yo, this guy's great, hard worker, wants to be an ER tech. Do you have a spot for him? He wants to transfer. If that's not the case, hey, they talk to you. They think, oh, dude, this guy's not going to do well, right? He doesn't know anything. He doesn't know what he's talking about. He doesn't know his left shoe from, yeah, he doesn't know what he's talking about. He does not have enough experience to do this. If that's the case, uh, you know, go get your CNA. If you don't have your CNA and you're going for it, go get your CNA, right? Or go get your EMT cert, whatever, and then transfer. And guess what? If they don't want you there, go to a different floor and get some experience on the floor. If you really want to work in the ER, you need to work on the floor. Uh, you don't have to. You don't have to work on the floor, but the best ER techs know how the floor runs too. You gotta. It's just a part of know the hospital system inside and out. Know what every role does. Being able to know what every role does really helps your proficiency and your ability to kind of adapt to scenarios because you know what everyone's job is and you know what the responsibilities are. And it's the same responsibilities. Honestly, well, not necessarily the same responsibilities. So I'll go over the responsibilities of the ER tech too because we'll talk about ER 101. I'll let you know what they do. So, or at least this is general. Some ERs have different spots. Some ERs don't let you do a bunch of stuff. So it just depends. But generally, I'll say these are possibilities. Or what? Maybe I'll just say what I've done. This is what we do. or what I've experienced. I guess I'm gonna stop rambling. So that's the way to do it: is go work for them. Maybe don't, maybe as an EVS worker, transfer to the floor, and then from the floor, let your charge nurse know, yo, I want to work in the ER. I think it'd be really great. I've been studying on it. I'm getting my EMT, blah blah blah, this that and the other, all this other stuff, and tell your manager and put in your application, and then go bring them donuts or something, and go down there and talk to them, just get to know them. If you guys kind of be bold about this kind of stuff, and if they don't want you, that's the way it goes. Try somewhere else. But honestly, if people like you and you're smart and you're trying your best and you want to be a nurse or you want to be a paramedic or whatever it is, and you want to learn and you're hardworking and you're not complaining and you're treating every day like it's treat every day. Okay, that's the other thing. So you basically got to treat every day like it's an interview. Everybody you're talking to, you're interviewed. You're being interviewed, right? First impressions are very important. How you speak with people, consistency is very important. Being consistent when you talk to people, being kind consistently, not getting angry with people or short with people, being easy to work with. Those things get you jobs. Those things make life easy for others. Those people, you want to work with those kind of people. You want to work with people that smile and who are looking out for your best interests and aren't trying to freaking trip you up every freaking second, right? You want to work with people that you like, and when you work with people that you like, or you start working, you are the person you want to work with. When you are the person you want to work with, and you are treating it like an interview, like this person has a say, this person's words matter, and how they perceive me is important. When you think those things, okay, some people, there's a lot of people who say, oh, don't care what other people think, all this other, oh, don't care about this, that, whatever, people say don't care, what people think or what people say, or how people perceive you. Don't worry about what others think. Well, you know what? When you give other people healthy respect and healthy authority to have a voice equal to yours, and you take it truly into account and you treat it as important, and people realize that, and people will enjoy working with people who are like that, and you will be beneficial. You benefit because when you speak to people, you'll maintain good relationships, and relationships get you places. If you want to be in the ER, you got to make relationships with people who are in the ER. It's just how it works, right? Some people in the ER are the easiest to make relationships with. I'll tell you that. So, you have to. It's a kind of political game you got to play to get yourself in there, and they don't let anyone in the ER, especially the good hospitals. You work at a level 1 facility or level 2 trauma and their cardiac and standard receiving, pediatric trauma and cardiac receiving. You know, and you're high volume. You have some incredible doctors on staff, and you're working for a freaking sweet facility with great. If you're working in a good hospital, they want the good people in the ER because that's the face of. I mean, that really is very important. Very important place to have good people. I think. Not that it's not important for everywhere. It's important everywhere. But the people who can't hack it, the people who with the best skills go to the ER. You can't have crappy skills and work in the ER. If you do, you will sink and drown, and they will kick you back up to the floor. They say, no, dude, you can't do this. You're not there. My phone died, so I had to plug it into a real outlet. So I'm gonna finish this thought. This is good. I think this is good information for me just to process. I think because this is just my personal experience. Um, so I don't remember where I was. Oh yeah, get it. So back to getting in the ER. So yeah, so those are the ways to do it. Um, getting a CNA, working on a floor and floating over is the same. You get a CNA, work on a floor in the hospital that you want to work at. Apply, say you're a pre-nursing student or a nursing student. Just call yourself a nursing student or majoring in nursing. You plan to be a nurse or a doctor or whatever, pre-med or whatever it is. And you have a CNA, and that'll give you plenty of precedence to work for a good hospital. They love working with people like that. A lot of hospitals do. So I don't know what this glare is on my camera, but whatever. Oh, maybe it's the tank behind me. It's the light shining off of the tank, glancing and hitting the camera with a trip. All right, so yeah, those beams of light. Oh, that's cool. Oh, okay. So like duties of an ER tech, you get like, so I'll just say how I did it at this place that I was at, the one place I was at. Oh, dude, my phone's gonna die again. It's okay though. Just so you know, my phone's dead. It's gonna die really soon. Um, so you take vitals, right? You get a lot of times you'll get a pod. If you're trauma, they got a trauma tech. Some places you have a designated trauma tech. You get to be the trauma tech. You're the only take trauma patients. You don't work on any other patients, and no medical patients, no surgical patients, no patients coming in coding, just trauma, and you take care of all the trauma, and you do all the wound care and all this other stuff. You know, you run the trauma with them. So there's some that are designated that. Of course, you can't just jump into it. You got to get yourself. Well, you know, some people can. I think that anything's possible. Anything's possible. You can jump into that spot too. Um, Back to what I was saying, I guess. In the ER, you know, yeah, you'll get like say 8 beds or 10 beds sometimes because you don't have to do the nursing stuff, so you're not thinking nearly have to think nearly as hard. Nurses will take 3 or 4 patients, two, 1, 2, 3 or 4 patients. ER techs they can take 8, 10. They can take the whole unit, 30 patients if you had to. But basically, let's say I have beds 1 through 8. All my patients in beds 1 through 8. When you come into the ER as a tech, and you're in a high ER, like high volume ER, when you show up, the place is gonna be chaos. The place is full. It's not like you starting and you're like waiting for your patient to come into your bed. No, you're showing up. You're relieving the current tech. The current tech's been freaking running and gunning for 12 hours, and the whole place is full, and all 8 beds are full of different patients, and they all have different levels of care required. They all have different pathos. They all have different presentations. They have different personal, social needs. They all have different stories and different problems and different levels of close to death. How close to death are each one of these guys? So when you get there, right, you get report. They're gonna give you all your beds. Boom, 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 boom. Maybe you have a bed open. Maybe you have two, three beds open. Maybe it's slow. Blah blah blah. Whatever. If you have open beds, that doesn't mean you don't have work. You got to stock those rooms. Make sure they have everything in them. Right. Check your suction. Make sure you have O2 adapters. Make sure you have bag mouth masks and all your suction works and is suctioning work right. You want to check all that. Make sure you got the bed is dressed properly. There's gowns that are snapped up and ready to go, right? Because they all have quick release snaps. So if you don't have your gowns aren't snapped up, you're not going to be able to put them in a gown, right? Make sure you have scissors and you have a stethoscope and you have pen light and you have everything you need, tape, you know, and all kinds of random crap that your techs need. Make sure your room is full. You have urinals and you have like you might have point of care HCGs in there. You might have point of care hemocults. You might have um, blood draw stuff, you know, close to the room. Make sure your room has linens. You check to make sure your room's stocked. Then you go check, and you're going to check your rooms that have patients in them. Make sure they're all on the monitor. Make sure the monitor is cycling per what they need regarding their status. So if they're really sick, make sure they're cycling faster pressures than slower. But make sure they're all cycling. Make sure they're on the monitor. Make sure they're all blood pressure cuffs are on. Make sure they have O2 properly set up. Make sure the beds are low and the rails are up and everyone's safe, right? So you're going to be kind of in charge of keeping the flow of the patient, getting the patient out of their clothes, getting them into the gown, and getting them on the monitor is part of your job as an ER tech when the patient comes on your side. Another thing would be help get a urine specimen. Maybe you can draw labs if you have phlebotomy. So that's like the core of the ER tech is facilitating. You may be transporting, right? If that patient needs to go to CT and they've been sitting for 25 minutes, transports freaking knee deep in a bunch of other transports, and no one can take this guy, and you got 10 minutes, and the nurse is like, yo, can you send him to CT? And we call CT and they're ready. Bro, take him over to CT, right? Or if the nurses come with us, take him over to CT. So you might help transport, right? If the patient comes in, they code, you're going to be the one on compressions. You're going to be the one getting a 12 lead, or you're going to be will be the one putting them up on the pads. You know, you'll be the one doing, you know, setting up the BVM for the RTs coming, cracking the airway box for them, uh, setting up the 12 lead recorder. Say that. So that's kind of another thing. Another thing is like wound care. Anyone who comes in with wounds that need to be cleaned or you know scrubbed or you know whatever, you are the go-to to wrap them up. Right? you cut off all the old dressings, you put all the new dressings, you clean all the wounds. You are assistant. You're directly assist. I've directly assisted with placing central lines. We'll directly gown up and mask and freaking cap and be not necessarily have to go sterile, but yeah, you can go sterile and help with suturing too. You may end up getting sterile gloves on and helping suture. You might not that you're going to do the sutures, but you're going to get the suture kit set up. You're going to do the wound care after the suture. You may help the doc giving whatever they need because you may need needles. They're sterile. And they might need to be able to put needles on to inject the lido. You have to set the lido, so they might ask. So if a doc needs to do some sutures on somebody, they have a cut or something. You'd say, okay, I want let's say it's a skin tear or skin cut, low, not super deep. Oh, my wife's waking up. Hey, she asleep? Cool. I'm just talking to myself. Nobody's watching this.
Okay, I'm gonna get some.
I mean, but this is live.
Oh, okay.
You're getting stuff.
I'm gonna get some chocolate.
Okay, all right. Chocolate it up. Okay.
Oh, yeah.
Love you. Good night. So, the doc will be like, "Yo, okay, so give me, let's say, 5-O-Proline and epi with, or epi without. So the epi with or without. They might just say with. So 5-O-Proline with Lido with epi. They might say. So you would get, you might set up the whole lac tray. You might crack the lac tray. You might set up the Lido for them. Make sure they have all the needles they need. Get the type. So there's like Proline. There's Ethelon. There's nylon. There's Vicryl. There's coated Vicryl. There's gut, Forma gut, chromic gut. There's a bunch of different kinds, and they come in zero point 0.0 to 0.7, I guess, the thinnest. And the 0.7 is the really fine-haired one, and the 0.0 or the zeros are like thick cords that you would pull like an abdomen together with, or like you'd pull a heart, valve together with, whatever, really thick ones. So they'll say whatever. Usually when it's like soft tissue, it's like Proline, something that's gonna not disintegrate, and then it'll be like 5-O, 4-O if it's big. They might take chromic gut and or Vicryl and Proline. So they say like 6-O chromic gut and 5-O Proline, or 5-O nylon, something, whatever. They'll give you a list of different sutures they want to use to close this wound and what kind of anesthesia you want, or not, or local anesthetic you want. And so you'll go set the lac trays up. You might help set up a chest tube. You'll definitely set up chest tubes if you're in a trauma center. So with a chest tube, you'll learn it's like you have usually it's like 3 different parts of the chest tube. So you have a chest tube, the tube itself that has a size and a type. So certain come with a trocar, which is like the little poker, like this big thick bullet in the middle of the big tube, and with or without a trocar. So they'll say like, I don't know, like 30 with a 32 with a trocar, or 34 with a trocar, or with or without a trocar. And then you'll actually have so that'll be in itself, it's a long tube. And then you also need a like a water seal chamber, and then you would actually need the kit to actually do the chest tube, do all the cutting and the suturing, all this, that, and third, whatever. So you'll have 3 different parts kind of to it. 2 of them are sterile pretty much. The one you just want to make sure when you give him the tube, you stay sterile. He's able to get a hold of it, and he's sterile. You may help kind of open up the chest tube kit with all the blades and everything. And just knowing where all that stuff's at is kind of important, So wound care, being able to set up procedures, 12 leads like crazy. I can't tell you how many 12 leads I've done because I don't know how many 12 leads I've done. But I've done 12 leads on walk-in SVTs. I've done 12 leads on right-sided STEMIs that turn while I'm freaking doing the 12 lead, like watching the ST elevation while I'm doing the 12 lead. I've seen, I've seen a bunch of STEMIs, lots of atrial fib with RVRs. You get a lot of AFib with RVRs. So you get all those, like, you get really familiar with 12 leads. And then if you really want to get into it, you have a doc who freaking looks at the thousands of these things, hundreds of thousands, probably tens of thousands of these things. So you can actually talk shop with your doc if you start learning how Precordia leads work and how the axis is valued, different PR interval, QRS complexes, QT interval, looking for ST segment elevations, looking for P waves that flip, how that's affected, like junctional rhythms. You can really get into it, learn all this stuff, and be able to apply it because you're taking the 12 lead and bringing it to doc, like, yo, I think this, that, and whatever, this. And they're like, yo, okay, I see what you're saying. And then, so not only that, you're also going to be printing out previous, because a lot of people getting 12 leads have previous 12 leads because it's usually chronic. So if they had a previous 12 lead, you print out and you can actually compare them. It's another thing we do a lot: print out the 12 leads, show it to the doc, the new one and the old one. They will sign off on it. So you'll do that. You'll chart vitals, INOs. You do compressions for code blues. You might set up and help transport STEMIs, and you might set up and help transport code strokes. What else do you do? I think you help with. Come here, kitty. Come here, kitty cat. She's right there. So, what else? I'm just like kind of brain dumping because it's fun. This is just stuff I learned, so might as well just dump it, brain dump it. Oh, this is live, so I can't really, just have to skip ahead of this if I come up with more stuff. I think that's it. Oh, triage too. You'll do triage, so you'll be the triage tech, which is kind of cool. So that's really fun too. Love triage. Nurses hate triage because it's scary, but as a tech with no like licensure responsibility, and you're working under the direction of a nurse, super fun. As a nurse, a little scary, a lot of scary, not fun, very stressful, high intensity critical thinking, evaluation, time management, and appropriate communication because we won't go into the nursing role. The nursing role is another freaking level, dude. Another level. ER tech role, so fun. Super fun. Uh, because you're right along, dude. You're right along, buddy, for the nurse. The nurse is in charge. The nurse is running the freaking conductor. You're right. They're conducting this. They're deciding what the ESI level is, emergency severity index. So the ESI, some people use ESI, some people use other stuff. ESI index is a 1 to 4 index, or 1 to 5, I think. 1 to 5. 1 is their coding. 2 is they're about to code. 3 is they're going to need labs and they're going to need imaging to find out what the heck's going on, and they could code. 4 is they're not going to code. They're stable hemodynamically. This is a, uh, maybe they have a genuinely real issue and they have to be treated, but it's going to most likely result in a discharge. And uh, 4 is not a problem. 4 is cool. 5 is like give them some Tylenol, give them an ice pack, send them out, send them home, right? So that's the 4. Also, if you're suicidal, I think you're a 2. If they're 5150, they're suicidal, it's a 2 because they're potential for date injury, very very high potential for injury. So you're going to have the nurse assign the ESI level, but as a tech, you're going to get a set of vitals, right? You get a set of vitals, get a little story because someone's got to hear the first story. If the nurse is taking care of 1 and there's 2, someone's got to get a story. You get them registered, right? It's a little bit of a gray area. Yeah, the nurse needs to do an assessment. Absolutely, the nurse is going to do an assessment. But guess what? The nurse is doing an assessment right there, right now, and I'm right here, right now, and I'm taking their vitals. So I'm going to keep talking to them while I take their vitals, and I'll pass along whether these vitals suck and whether this story needs to be told for that person's story, right? I can say, "Yo, come over here a second," or "When you're done, please come over here," right? So you can. And then so you can help them kind of fill out registration, get them registered, put an armband on them. If they're really like crap, you're gonna put them in a wheelchair and say, "Yo, somebody needs to wheel this guy back here, right?" Or I'm gonna wheel this guy back here. Someone needs to take this guy back. Blah, blah, blah. whatever. Just advocate and kind of say something. Get a next second. Hey, guy, we need a second set of eyes on this guy, please. We need a second set of eyes on this guy. Somebody needs to take a look at this guy's skin, right? He looks like it's like a ghost or whatever. So you wouldn't say that, but I'm just saying that's what you see that, and that's what you might say. So plus also as a triage tech, when you get walk-ins, someone walking through the emergency department walking, and they have any kind of sign of anything that might be even slightly construed as cardiac related, uh, or hemodynamic instability, pretty much they need, or chest pain. I should say mainly chest pain. Mainly anything that could be construed as chest pain-like symptoms or heart attack STEMI-like symptoms, they need to have an EKG within 10 minutes as a standing order at all times. You don't need an order. Get them on the bed in the back, take them in the triage room, and get an EKG on them and get it to the doc if it's a problem, right? Fast. So within 10 minutes of the walk-in time, the timestamp of when they signed the "you can take care of me," within 10 minutes of signing their life away to us, they need a 12 lead, and that 12 needs to be seen by a doc, because that's California state law. I don't know if that's anywhere else, but I mean for sure in California, you can't walk in without getting a 12 lead if you have anything like chest pain, jaw pain, epigastric like tightness, any kind of nausea with history, kind of multiple comorbidities, smoking, diabetes, hypertensive, smoking, diabetic, obese, hypertensive guy coming in pale and shortness of breath, or chest pain, or any kind of weird kind of stuff like that, needs a 12 lead. Any kind of suspicion needs a 12 lead. If you don't, that's not good. It's really bad. I think the hospital gets dinged a lot, like $100,000 or something, or 10,000 or something stupid, a bunch of money. And people come and start snooping around, and be like, "Yo, why aren't you getting your 12 leads right?" So that's another responsibility. And I'm getting tired. I think that's it. That's what you do. I think that's EMS. I mean ER Tech 101. That's the basics. Sure, there's more. There's a lot more. There's always more. There's always more. But that's what I can think of right now. You get to do the exposures where you cut people's clothes off too. You have those trauma shears, dude. Keep your trauma shears, because you're gonna end up cutting clothes. Lots of clothes get cut off. Belts. I almost cut through a guy who had $1,000 in his pocket, cash, sitting in his pocket, as I'm about to cut his pants off. Thank goodness he was still coherent enough to say, "Hey, there's something in my pocket." And I'm not. I mean, usually you wouldn't cut the pockets, and you're gonna feel around, see if there's stuff in there. But that's another thing. I don't think anything else. Some places might let you take out IVs. I don't know. I think that's actually not appropriate. I think that's out of their scope of practice. But I've seen it. The nurse will say, "Take out the IV." I'm not down for that. Not down for that. Not about that. And the reason I'm not about that is there's multiple reasons why. But one would be if the IV that the tech didn't put in is not intact all the way, and there's a piece missing, and it floats up and causes injury somewhere, and he doesn't look at the tip of the catheter, right? Look at the tip of the catheter and see that make sure it's the right size and is not broken off or anything. And before they throw it away, if they're not able to do that, how am I ever going to know? Plus, the patient, that ear tech is not looking at the PTT. He's not looking at the INR. He doesn't know what the platelets are, right? And he doesn't know if this person's on aspirin. And he's going to start pulling stuff. And, if this patient doesn't clot, or, we need that IV, he pulls it out, and actually I need that IV. Okay. It's just not good. It's not good I don't think it's good for ear techs to pull out IVs. This is me. So, but I've seen it. You might be able to strip bags, stripped a bunch of bags. But also as a nursing student, like I'm also a nursing student, so it's a little different. But I mean, I think it's within the scope of practice of an ER tech to strip a bag. You can strip out a bag. What I mean by strip a bag is you got 1,000 milliliters of normal saline. They call it a big bag, or 1,000 milliliters of normal saline. I don't know, you call it whatever you want. But stripping about a bag would be like you there's two parts. You have a bag, and you have like the little tubing, and it's all coiled up in a little easy rip off, tubing. And it's got a little roller clamp on it. I'm gonna flip this around. Sorry. It's got a little roller clamp on it. And has a little chamber at the top with a little spike. And you spike it, and you squeeze a little thing, and you open it up and prime the entire tubing. And you wrap it up and hang it. Let the nurse hook it up. So, I mean, I don't know if that's within the scope of practice. It might be. But that happens. You do that. You restock a lot of restocking. If you don't have patience, you're restocking, right? And you'll coordinate too. There's a lot of coordinating with the charge nurse regarding patient movement, because you may be transferring patients up to the floor, helping push patients up the floor. You may be moving critical patients into the code rooms. We used to call one of these hospitals I worked at. We call OSB, bed 1 and bed 2 are OSBs. OSB stands for oh shit beds. That's the oh shit bed. Oh shit, get him in that bed. So OSBs 1 and 2. So they'll be like, put him in OSB. Yeah, let's move him to OSB. And open up 8, and we'll move them to 8. And so, you might, help DC everything, or help transport patients to different beds, different rooms. You clean the beds, you clean monitors, you hook them up to the Zols when you're transporting. Yeah, you just, this is a fun gig. A lot of work, dude. I was at a high acuity ER, and there's a few videos that I've taken. Any video where I have a little stethoscope and I'm in black with a beanie on, that's working night shifts in a level 2 trauma center. Like, they get 60,000 patients a year, pretty full. They can take a lot of cool stuff that comes through there. So that's me working there, and that's kind of what I was doing. It was fun. I loved it. It was a blast. You can help with NGs too, like help the nurse with the NG, help set up the suction, help go get everything for them, set up for them, get the water, hold them. You can help. You can help with any nursing skills pretty much. If you're papoose, oh jeez, you papoose patients, you're the guy. Oh, okay. So, all right. So here's some more stuff. So you papoose the guys, babies. Papoosing a baby. You wrap them in a blanket. You wrap them in pillowcase, and then lay on top of them, hold them down while the doctor pokes them with needles. So they scream the entire time. You gotta hold their head straight, really tight. Hold their head, but don't squeeze the head while the parents are watching. But you gotta hold it as firm as you can, but try not to hurt the baby. Yeah, that's fun. So you do that a lot, holding babies' heads and holding babies' bodies and holding babies' arms. Oh, you get to help ortho reduce dislocations and fractures. So ortho will come in, and when you got like long bone fractures for little kids and stuff, or complex dislocations, you'll be there while they moderately sedate the patient. You'll be sending the vitals. You'll be helping. Oh, splinting. So you do splinting. Oh, you do a lot of stuff. You do a lot of splinting. I knew there was more. I knew there's more. I'm digging more up as I keep talking. You do a lot of splinting. You learn all these different splints. So you have like volar splints. You have sugar tongue splints. You have coaptation splints. You have short leg posterior splints, long leg posterior, long arm posterior. You have ulnar gutter splints, digital stuff. You can splint digital for your fingers. You get to look at all the radiology before you do it. You got fiberglass. You can use plaster. You help ortho when you reduce it too. So you'll reduce, or you help bring the bone back into place and then wrap it up while the patient's sleeping. You do fun stuff. Other stuff is when there's code gray. So code gray is when there's a violent patient or like a psychotic patient, and restraints. So you do code gray takedowns. You do the restraints. You do sitting, so you might sit on that patient as one-to-one. So you'll just basically, you can't work at all. You just sit there and watch them, make sure they don't kill themselves or anybody else. They don't leave the room. So you'll do all that stuff too. So papoosing and holding for mod seds and suturing. You help with suturing. You help with the light, and you'll like work hand in hand with the doctor while he's suturing these complex lacerations. It's fun, dude. You get to be a runner. So you do a lot of other stuff actually. Yeah, splinting's fun. Yeah. There's a lot of stuff. This is a lot, dude. I think I'm laying it all out, man. This is it. This is the stuff, dude. And it can get busy. I don't know. I never was not busy. Literally, never. I'd run 25, 30,000 steps. I had a little step counter on my phone. I kept my phone in my pocket the entire time. And I look at my phone the other day. Freaking 30,000, 40,000 steps. It was crazy. You're stepping like crazy. I was running and gunning, dude. That was fun. And I was working out on my weekends, or my 30-minute breaks. So I'd run and gun in the ER, take my 30. I would fast all 12 hours. I was crazy. I would fast all 12 hours. So I can't eat at night. I have green tea or coffee, black coffee, and I do a little workout. So that maybe that's why I'm like make these videos. Like I'm making these videos right now. Yeah, I'm tired, but it's nothing. This what I'm doing right now at 10 o'clock at night. I'm tired after a 12-hour shift and ready to go to bed. I actually worked 3 12s. Just got on my third 12. I worked 11 a.m. to 11:30 p.m. in the ER at my hospital. Then I came back the next morning at 7, so I got to bed at like 12:30. Woke up at freaking like 5:30. Worked 7 to 7:30, and then did it again today. So that's 3 12s. And I'm good enough right now. I got one day off, and then I'm working again Monday. Off Tuesday. I'll have one day to study for my final. Last test is a whole freaking semester. and then I take my final Wednesday, and freaking nursing school is basically done. I have 2 more clinicals after that, and it's home stretch, and then we're done. 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 So I'm gonna bring donuts and get my preceptor a $20 Starbucks gift card or something. Get her $20 Starbucks gift card and bring donuts. That's nice. Oh, another thing, when you got pediatrics, you got to get a height and weight when they come in through triage. You're going to be getting the one getting the height and the weight on the kids. So you're working womb to tomb, which I think is so great. I love that, womb to tomb. So you get neonates, you get little newborns. The youngest I've taken care of is like 4 days, I guess, 4 days old. 3 days old, I've had to do 3-day-old babies. Change their diaper, weigh them, rectal temps, you name it. I've done a 12 lead on a 2-year-old a couple times. I had a 2-year-old with a freaking code stroke on a freaking 2-year-old. That sucked. Doing a 12 lead on her. That sucked. I thought it was just like, she looks just like my daughter. And she was on my little finger too. She felt just like my daughter. So crazy. What else? Yeah, so you weigh a lot of kids, you talk to a lot of kids, you talk to so many patients. It's great for your patient care. You work in a high volume ER. And work somewhere where you have to, I've been working my Spanish. I see this every time, but my Spanish is getting so much better. I'm getting pretty good at my Spanish. I'm getting there. I can say a lot of stuff. I'm so excited. Been using Duolingo. All right, I think that's it. I'm gonna call it. That's it. Whoever. Oh, I got somebody watching this. Hey there. What's up? Been blabbering, stammering, yelling, ranting about all kinds of craziness for the past. I don't know how long. I don't know how long it's been. But I'm just about to crash. This is too much. I'm exhausted. Oh. You know, it's kind of funny. It's like I don't put any hashtags in this. I don't put any descriptions. I don't give my name. You know, I try to stay as low profile on this thing as possible. Least amount of people as possible, you know. I don't edit them. I don't say subscribe or like or comment. I stopped doing that a while ago. Like I'm not asking to freaking subscribe. I don't care. I'm over it, you know. It's not this is for me, I think. It's more for me. And you know, if people want to tag along my journey, I'm super down, but I don't feel the need to encourage anyone. Uh I don't feel the need to encourage anyone to jump in. So, not necessary. All right. I guess that's it. So until next time. Next time I make this video, I'll probably have like probably finish the final. So that's it.